I welcome everybody back. Though it's post lunch, I hope the gateway to intellect is not closed. Now we move on to fourth session, which is echo in structural heart diseases, and we'll have a very detailed and exciting presentation. I request my students to introduce the speakers.
I'm here to introduce the next speaker of the session, Dr. Vijay Sai sir, HOD Senior Consultant, YPH Institute of Medical Sciences and Research Center, Bangalore. Sir completed his MBBS and MD from Gulbarga University, DNB Cardiology from Sri Satya Sai Institute of Higher Medical Sciences, Prashantigram, and also worked as a senior consultant there. Sir is a fellow of Society of Cardiovascular Angiography and Intervention. I welcome you, sir.
I'm here to introduce the second speaker of the session, Dr. Vijay Kumar sir, Assistant Professor of Cardiology. Sir has completed MBBS, MD from Mysore, DNB General Medicine from JIPMER, DM Cardiology from Jaideva Institute of Cardiovascular Sciences, Bangalore, DNB Cardiology from Gangaram Hospital, New Delhi. Sir is the gold medalist in MBBS. Sir has secured second place in Capicon 2007 at Manipal, and Sir has been awarded for the best case presentation at MM. Currently, Sir is working as the Assistant Professor of Cardiology in Sri Jaideva Institute of Cardiovascular Sciences, Bangalore, and also as the Associate Consultant Interventional Cardiologist at Apollo Hospitals, Bannerghatta. Sir, we welcome you.
I now request Dr. Vijay Sai sir to give us his talk on echo in congenital heart disease. Can I just request all the delegates to please settle down?
These are oft repeated questions. Please pay attention. Everybody should settle in quick. Every single year, you will get these papers in various forms. Sir is ready to start.
And the one thing I just say before sir starts is everybody is scared of echo in CHD. Don't be. It's easy. Sir will allude to these points, but then as ma'am said, every year we are told to put a few questions when we set the paper. So sir, please sir. Thank you so much.
Pranams at the lotus feet of Bhagwan Baba. Thank you for the opportunity. It has been, I think, when I heard this is happening in Satya Sai, the idea and the concept was excellent. So I was feeling importance has been given to the CCT course now actually. So I feel probably we should continue to do this, and then a lot of people will benefit definitely, like we have been doing speed conference. So congratulations again to the Satya Sai team. So my topic for today is echo in common congenital heart diseases. It is difficult to cover all the congenital heart diseases in the time given. So I'll run through some of the common congenital heart diseases what we see in the OPD setup, like atrial septal defect, ventricular septal defect, PTA, and then tautology fallow. So when we come to ASD, it's one of the most commonest congenital heart diseases. We can have ostium secundum, ostium primum, sinus venosus. It can be SVC type, IVC type, and then coronary sinus, which is also called as unroofed coronary sinus. Some of the commonly associated anomalies with ASD. If we have an ostium secundum ASD, we can have some atrial septal aneurysm in some patients. Ostium primum ASD, we can have cleft mitral wall. In sinus venosus ASD, it is usually associated anomalous drainage of pulmonary vein. It is right upper pulmonary vein. Then in unroofed coronary sinus, usually goes along with persistent left superior vena cava. Yeah, you have, I think, heard about and then seen a lot of patients with ostium secundum, ostium primum ASDs. So I'll just tell a few things about inferior sinus venosus defects. They're also called as IVC defects, much less common, not commonly seen in the OPD practice. Only in institutes you can see probably, and they're located immediately above the orifice of the inferior vena cava. These defects are also often associated with partial anomalous connection of the right pulmonary veins to the junction of right atrium and IVC. Unroofed coronary sinus, also known as coronary sinus defect, is much rare. It's caused by absence of part or all of the common wall between the coronary sinus and the left atrium. That's the reason it is called as unroofed coronary sinus. They normally present with unexplained cyanosis. Normal workup for cyanosis will be negative. When we see an echo or probably transthoracic or transesophageal, we can come to know whether it can be unroofed coronary sinus. So this defect, as we said, it is less than 1% and is commonly associated persistent LSVC. We have various modalities for diagnosing atrial septal defect. It can be transthoracic, transesophageal, 3D echo, intracardiac echo. When do you suspect in a 2D echo? The practice, what has been happening in Sathya Sai in Whitefield and in some few centers are patients directly come to the echo room to do an echo. So I think you will be challenged by the presentation. What happens with us is, or in many of the centers is, doctor examines the patient, gets a history, then he comes to a conclusion, then goes to an echo room. So he has a lot of information at his disposal. But I think here you get, it's like an examination for you actually. Like in examination, how it happens to diagnose, it is the same way. So there, when you do an echo, you should be suspecting ASD whenever you find right ventricle and right atrial dilatation, abnormal motion of the IVS, which is brisk anterior movement in early systole or flattened movement throughout the systole, and an IAS dropout in apical four-chamber view. And you can calculate the relative atrial index. This relative atrial index, it's a simple, reliable, and robust TT indicator of atrial defects. We calculate the areas of RA and LA. It is the ratio of RA area by LA area. Cutoff value of more than 0.92 predicted patients with ASDs versus matched controls with 99% sensitivity and 90% specificity. So this is a good marker. When you see a patient with directed RARV, you can calculate this and then come to a conclusion or maybe suspicion of atrial septal defect. So whenever you find an echo RARV volume overload and then septal flattening in diastole of the IVS in the short axis view, and then you can come to subcostal four-chamber view, which is the ideal view to profile the ASD because it keeps atrial septum perpendicular to the ultrasound beam. And you can distinguish ostium secundum, ostium primum, SV type of ASDs. You can probably consistently visualize the SPSs very clearly, and also the PAPC of the right upper pulmonary vein. So here the marker will be breath held in inspiration and marker in 3 o'clock position. So if you want a short axis in subcostal, marker will be in 12 o'clock position. So this is a subcostal four-chamber view, upper diagram. You have RARV, then LALV. And this is short axis view, shows IVC leading to RA and district involved. Some of the other views in transthoracic imaging for ASD is basal short axis view, where the IA separates the right and left atrium and runs exactly posterior from the non-coronary cusp of the atrial wall. So not seen in entirety as a result of dropout artifact. So then you can come to apical four-chamber view, but it is not the best of the view to profile ASD because otherwise also you can see a dropout. You can see the drainage of pulmonary veins. So normally 3 veins are draining to A. And in 5-chamber view, you can visualize the anterior aspect of the interatrial septum. So this is the basal short axis view. The AS runs just behind the non-coronary cusp, and then you can see a dropout here. This is the 4-chamber view, seeing the pulmonary vein drainage and the interatrial septum. We can come to a fairly good idea about QPQS also to know the significance of the ASD. When you have diagnosed the patient with location, then size of the ASD, then you try to see the hemodynamic significance of the ASD, whether it is causing shunt of less than 1.5:1 or more than 2:1. Then what are the associated anomalies and the pulmonary arterial hypertension also. So you have, I think all of you have gone through these formulas where we calculate the cross-section area of RVOT and then take the time velocity integral, and then you come to conclusion of QP by QS. So when you want to diagnose the associated anomalies along with ASD, you can be searching for pulmonary vein abnormalities and drainage abnormalities. Usually, they're all associated in 95% of SBASDs. It is commonly goes with drainage of anomalous drainage of right upper pulmonary vein to SVC. But you can find some different combinations also. One more view, it is called as N-phase view in 2D. You can take first the apical forceps view, then the marker is at 1 o'clock, keeping the atrial septum in view and ASD in the region of interest. The transducer is rotated counterclockwise, approximately 45 to 60 degrees. So this is what is N-phase view. This is four chamber, then counterclockwise rotation. It will give the size of the ASD in a much clearer way actually. So along with that calculation of QP by QS, you can calculate the pulmonary arterial systolic pressure also by either by pulmonary acceleration time or by tricuspid regurgitation, evaluating the RVSP and seeing the IVC collapsibility. Some of the limitations to color flow in the diagnosis of ASD. It can be like ghosting of the color across the internal septum, because sometimes gives a false impression of shunt flow, particularly with apical fourth chamber. And ASD can be missed by TT when there is associated severe pulmonary arterial hypertension, because you are not able to see the flow across ASD because of the pH. The flow is not very obviously seen there. So in these patients, probably you can do an agitated saline injection or a transesophageal echo. Once you have decided that ASD is there, the size of the ASD has been seen, the hemodynamic significance has been known. So probably then you have to decide whether patient can go for device closure or surgical closure. So device closure, when we plan, you have to see the rims also. The SVC rim, IVC rim should be profiled in the aortic rim also. One of the most common deficient rims which has been seen in the studies is aortic rim. The other septal abnormality which can be seen usually in commonly presenting to the OPD, like one of the entities atrial septal aneurysm. This is basically an abnormality of internal septum. You have protrusion of the internal septum by at least around 15 millimeters in the plane of IS with the respiration. So this is there, then you can probably come to a conclusion of atrial septal aneurysm. The base width should be more than 15 millimeters. Then probably you have a doubt about ASD size and then whether suitability is there or not for the device. You can probably subject the patient for transesophageal echo. There are several views starting from 0 degrees, where in this view we can see a centrally located ASD with the shunt. And this is again a large second ASD. This is an ASD with a deficient aortic margin. This is a ASD which is very large with deficient both aortic and posterior margins. So aortic and the posterior margins are deficient here, so not suitable for device closure. You can also see in some patients multiple ASDs, one in the upper part of the septum, the one in the middle part. So coming to the nomenclature of ASD, for the rims of the ASD, you can have, there are 4 important rims. There are 6 totally. So one is the aortic, which is superior anterior, AV, atrioventricular, this is mitral or inferior posterior, SVC rim, IVC rim. The most important rim out of all these things is IVC. So this is a bicable view showing in transesophageal echo, the 2 rims, IVC and SVC rim. The diagram showing multiple views in transesophageal echo, showing different types of rims which are seen in here. So the criteria to say whether this patient is suitable for device closure is, it should be at least 5 millimeters. And out of all the rims, IVC rim is the most important. These are the degrees and then levels of the TE where you can profile the rims. Some of the pictures where you have adequate rims for device closure. On the left side, we have an ASD which is measuring around 20 millimeters with adequate posterior rim. On the right side, we have adequate AV rim. So this is an AV rim. This is a ASD with good posterior rim. This is a picture showing deficient aortic rim. And this is again a bicable view showing adequate rims. You can probably bring in 3D echo also if the facilities are available to do the imaging for ASD. These are some of the views for the ASD to evaluate the size and the rims. These are again the views like we saw it in N-phase view. This is the same as N-phase view in 4 chamber, showing clearly the rims of the ASDs. And then atrial septal aneurysm and then multiple ASDs. So usually until 34 millimeters, ostium secundum ASD can be subjected for device closure. Rims except the anterior superior rim should be at least 5 millimeters, and dimension should be not smaller than the left atrial disc of the chosen device. So how do you measure the maximum size of the ASD? You should take at least 2 orthogonal views, and then maximal ASD diameter must be measured at the end of the ventricular systole, and 2 orthogonal views should be profiled. There is one entity called as complex ASD. This is nothing but a large ASD which is measuring more than 25 millimeters, mal aligned septum, multiple ASDs. You have one in the upper portion, one in the lower portion, and ASD with atrial septal aneurysm, and ASD with deficiency or floppy rims, and ASD with associated lesions like MS and PS. So to subject the patient of ASD for device, you should have a proper case selection. Important to have inferior and posterior rims, and anterior rim is not as important as the device will grasp the aorta. Coming to VSD, one of the commonest lesions in OPD practice. You can have a perimembranous VSD, you can have a muscular VSD, outlet VSD, inlet VSD. So this diagram, I think all of you are used to. You have the parasol long axis view, basal short axis view, LV short axis view at the mitral wall level. This is 4 chamber, this is 5 chamber. So we have the color code here. Perimembranous VSD is yellow one, which can be easily profiled in plaques view. And this is the short axis view, which will give us a lot of information. This is perimembranous. This is the infracrystal. This is supracrystal VSD. So whichever VSD you see near the pulmonary wall, this is outlet VSD. And again, in the LV short axis view, you have inlet VSD, you have an apical VSD, and you have midmuscular VSD. And in apical 4 chamber view, you have an inlet VSD wherein you find both the AV walls at the same level. Whenever you find both AV walls at the same level, you should suspect an inlet VSD. And when the VSD opens, when you are opening a 5 chamber view, that is again a perimembranous and a subaortic VSD. Swiss VSD, you have multiple muscular VSDs. You have an entity called as Gerbode defect where there is a lack of AV septum. You have a shunt from LV to RA directly. It can be again type 1 and type 2. Located in the membranous portion of the AV septum, it should send from LV to RA. Very uncommon, and it's a very small shunt. So you have several classifications for the VSD. Where one is a small VSD based on the size. They compare with the aortic root, less than 1/3 the size of the aortic root. Moderate VSD, which is half of the aortic root, and large VSD, which is larger than the size of the aortic root. Based on the pressure, QPQS less than 1.4:1, it can be restrictive VSD, and in non-restrictive VSD, QPQS is more than 2.2:1. Based on the ventriculography, you have a tubular type, you have a window type, you have an aneurysmal type, you have an infundibular type. So whenever you do an LV angiogram in laxo view, you can come to some conclusion about the type of VSD. So echo in VSD, again, the basic thing is to identify and diagnose, locate the VSD, number of VSDs, see the associated anomalies, and assess the hemodynamic significance of the VSD, whether it needs any treatment or no treatment. So you can know the number, size, and location. You can estimate the PA pressure by Bernoulli equation. You can identify the associated defects and then establish the magnitude of the shunt. These are all diagrams showing various types of VSDs. You have this is a classical short axis view. At the basal level, we have a perimembranous VSD, which is just seen adjacent to the septal leaf of tricuspid wall at 11 o'clock position. Again, the color flow showing the shunt. So whenever you do an echo, you have first you will be going through the 2D echo. In the 2D echo, you can come to a conclusion when you see a dilated LA and LV. and then you can take a ratio of LV to aorta. So if that is more than 1.5 to 1, then you probably conclude that it is a post-tricuspid shunt. So you can come to conclusion whether it is pre-tricuspid or post-tricuspid, depending on the size of LALV and RARV, and then ratio of LV to aorta. So I'll run through these pictures. I think probably all of you would have seen this in textbooks. So this is a muscular VSD. So what is the level of shunt? Like in ASD, how we calculated QP by QS. Again, in VSD also taking the LVOT and RVOT area, we can come to a conclusion of QP by QS. If you have more than 2:1 and if there is evidence of LV volume or load, then it is significant shunt. If it is more than 1.5:1 and PA pressure is less than 2/3 of systemic pressures and PVR is less than 2/3 of SVR, you can say it is probably a moderate to moderate VSD. And if the shunt is less than 1.5:1, it's a small VSD. Probably patients who have got large VSD associated with PAH, they need surgical intervention or a device closure. The other patients who require intervention is patients who have got history suggest of endocarditis. Asymptomatic patients, we can't subject them for treatment either by device or surgery. You have an echo feature whenever there is a high velocity jet through the VSD. There is no evidence of LA or LV volume or load. There is no evidence of pulmonary arterial hypertension. And when you subject the patients for cath, you have QP by QS less than 1.5, and then mean PA pressure is less than 25, and there is PVR is normal or less than 200. So this is a diagram showing LV volume overload, Z score of more than +2. And this is again trying to estimate the RV pressure depending on the gradient of the VSD. So whenever you have a child or probably a teenage who comes to an echo, you have a gradient across the VSD. You can indirectly calculate the RV pressure also. Suppose you know the systemic arterial pressure, you can come to a conclusion of RV pressure also. This is again formula to calculate QP by QS. When you come to deciding whether this patient is suitable for device or surgery, you have to see whether how are the rims to the neighboring structures and any contraindications for percutaneous closure and the size of the defect. Not all VSDs are amenable for device closure. Common VSDs which are amenable for devices, muscular VSDs, and some of the perimembranous VSDs, which have got adequate rims. So this diagram again showing the short axis view of the heart at the basal level, at the aortic wall level with the PA, that is perimembranous VSD on the left upper corner. Then you have a supracrystal VSD on the left lower. On the right, plaques view showing perimembranous VSD. The VSDs which are not amenable for device closure is inlet VSD and outlet VSD. So these VSDs will not be able to close by device. The same diagram again showing not suitable for device closure is subpulmonary or inlet VSD. So if you see the defects, when we take the implanted device for membranous VSD, the diameters are usually 4 to 18 millimeters, and the rim between defect and the aortic wall should be at least more than or equal to 2 millimeters. This is what you have to remember. And if you see, when you take a very PFM VSD coil, the effective diameter should be less than 8 millimeters. Then only we can put this coil, and no aortic rim is required. And the aneurysm, if it is present, it is preferable. So in summary, these are the things for device, adequate indication for closure based on the hemodynamics, perimembranous or muscular, diameter suitable for device closure, and adequate trims for the neighboring structures, and no contraindication. Inlet and outlet vases are not suitable for device closure. PDA, it's a communication from thoracic aorta to the junction of LPA and MPA. You can again try to diagnose it by 2D echo, M mode to see dilatation of LALV, and 2D echo again to visualize LALV dilatation. Then you can employ color, pulse wave, and then continuous wave also to evaluate the hemodynamic significance. You can employ many views, starting from plaques view to see the LALV volume overload. Then you can go to the basal short axis view to visualize exactly the size of the PDA, and then shunt, whether it is left to right or right to left or bidirectional shunt. So the best view to profile PDA is the basal short axis view in the parasternal area, where we can see clearly the ductus connecting the PA and the descending aorta near the origin of LPA. The suprasternal view is one more view which can be used to profile the PDA and the length and the ampulla at the aortic end and the pulmonary end and the narrowest diameter. One more view, which is the modified basal short axis view called as ductal view. It's also called as a three-legged pant view, which can be done routinely also when we have a basal short axis view. You have to move the transducer laterally and inferiorly to an infraclavicular position, rotating clockwise. So you have, this is a 2D picture. This is again with color. You have, they also call it as three-legged pant view. 1, 2, 3, RPA, LP, and PDA. So this is again a apical four chamber view showing the dilatation of LALV. Once we employ the Doppler modality, you can see the direction of shunt, which will supplement the 2D imaging. So whenever you have a normal pressures in PA, the high velocity turbulent flow is easily seen in both systole and diastole. So whenever you have the red flow in PA, when you are doing a basal short axis view, you should suspect some shunt is happening from something like PDA, or probably an AP window should be there. You have to suspect when you come to basal short axis view. Again, you can employ Doppler, either peridoulo or continuous wave, to evaluate the degree of left-right shunt and assess the pulmonary pressure. You can take help of PR, or you can measure the gradient across PDA only to have the idea of level of pH. If you see, for example, large PDA, it will have very, very low peak systolic velocity or low or absent diastolic velocity, and there can be flow reversal in descending aorta. So in large PDA, you have continuous runoff in the branch PS and in the aorta, which is proximal to the PDA by pulse wave. So you can assess PA pressures with the help of TR or knowing the gradients across the PDA. Again, as we discussed by M mode, we can know the LA to aorta ratio more than 1.5:1. It is suggestive of significant left to right shunting and increase LV internal dimensions during diastole. Trans-esophageal echo is not of great help in visualizing the PDA. So current practice is to suggest device closure. If it is less than 2 millimeters and less, coil closure is the best treatment of choice. If it is more than 2 millimeters, device closure can be done. If it is more than 12 millimeters, septal device or VSC muscular device can be put, or stent, or a surgery. So coming to one of the commonest cyanotic congenital heart diseases, tetralogy fellow, it consists of large unrestricted VSD with overloading of aorta with infundibular or valvular obstruction and right ventricular hypertrophy. So you have to know what is the location of VSD, know the level of RVOT obstruction, whether it is infundibulum, valvular, supravalvular, or peripheral, and know the coronary anatomy, and know the size of the branch PS. Get to know what is the size of the PS compared to the thoracic aorta, then whether any other additional defects are there or not. So basically, off late, we are deciding the patients to take up to the surgery based on echo only. So nobody does an angiogram for the TAF. Only we do angiogram to profile the coronary anatomy, or probably to see any collaterals are there or not. So many of the things are decided based on echo. So whenever you do an echo for a TAF patient, you should be thoroughly clear. The coronaries are not crossing the RVOT, the type of VSD, location of VSD, and the branch PS size. So this is the classical plaques view showing the area where the VSD is located, and then overreading of aorta in LALV, and here the pulmonary trunk and aorta. So aortic overreading, it's because of the malalignment. It can be variable between 15 to 95%. So it can be associated with rotation of aortic cusps. The right ventricular obstruction can happen at multiple levels. It can be infundibulum, or it can be valvular, supravalvular, or peripheral. So peripheral will not be able to make it obvious on the echo, but I think you can at least try to profile the 3 levels of obstruction across RVOT by echo. Branch PA size, we try to assess the McGunn's ratio by measuring the size of the PAs in the basal short axis view, then you try to take the size of thoracic aorta at the level of diaphragm. And then if the ratio is more than 1.6, then probably patient can be taken up for total correction. If it is less than 1.6, you have to do a palliative operation, like either BT shunt or Glenn or Watterson or Pod shunt. So these are the various coronary abnormalities which can be seen in tetralogy of fellow patients. You can have a small coronal branch or a large coronal branch, or LED coming from RCA, or whole of the LED and L6 coming from RCA, and single left coronary artery. So these things can be profiled, or maybe you can hone up your skill slowly, and then once you are thorough with routine echoes, you can try to spend more time in the basal short axis view to profile the coronary anatomy. Usually, whenever we have a coronary artery crossing the right ventricular outflow tract, this is important from the surgical point of view. The surgeon will not be able to do a transannular patch. If the distance is more from the coronary artery, then probably they can try to do. Otherwise, you will have to do a palliative shunt only. If the major coronary artery is crossing RVOT, then they'll not be able to perform a transannular patch. So you'll have to use a conduit if major coronary artery is crossing from the across the RVOT. Then you come to an assessment of aortic arch, especially important when you're doing a palliative shunt. So usually right aortic arch is commonly seen in around 20 to 25% of patients with TOF with the mirror image branching pattern. And also you can assess the level of collaterals, probably in adult TOF, not in children, to know whether they need any coil closure or can be managed medically. So these are pictures. I think they're all quite small. Probably you're not able to. I think last bench probably may not be able to see. I think just to profile and then show what exactly can be seen. This is the basal short axis view showing the location of VSD with coronal septum and pulmonary wall. And this is again turbulence across the pulmonary wall showing the obstruction. Again showing the obstruction across the RVOT and then valve. Of late, we have been seeing many patients who come back for checkup after the surgery, post-operative patient of TOF. So they come back every year for an echo. So in such patients, you should be able to profile whether they have got any residual VSD, whether any significant pulmonary regurgitation is there or not, RV dilatation at the base, at the mid, at the apex. Probably there are several things to be seen in post-operative patient. You can inherent to TOF repair, whether any residual VSD is there or not, and residual RVOT obstruction. And in any acquired lesions, it has happened over a period of time. Tricuspid wall abnormalities, TR can be seen, RVOT aneurysm can be seen, RV fibrosis can be seen. And there are some functional abnormalities also. Because of the PR, it can be causing RV volume overload, it can be causing RV diastolic dysfunction, it can cause RV pressure overload. So these things to be carefully profiled so that you can help the patient in or the doctor in managing them in the OPDs. So you have these are the abnormalities which can be seen in TOF patients. Thank you.
Thank you so much, sir. Actually, it's a very exhaustive topic because, as sir said, congenital heart disease is, very, very exhaustive. There have been questions which I've asked, which sir has covered very vividly. It's ASD is asked, VSD is asked, as sir said, and sir is himself a paper setter and of course a corrector. TOF hemodynamics, I was discussing with Vijay just now. TOF hemodynamics was asked a couple of times. Echo is asked. There's a lot of amalgam of echo, ECG in TOF, ECG in ASD, echo in ASD, as was discussed earlier as well. I think most topics have been covered, sir. Thank you so much for the overview. I request Rita ma'am to give a small token of our gratitude to sir. And this for sir comes as a blessing from the master, for whom he is also a student of from Shims Prashanti ground. Oh, I'm so sorry. Thank you, sir. Thank you for the overview.
Saw an echo report once, and all the rims were measured very correctly. Echo rim, the ASD rims, and at the end it was written TOF. See, ASD will be there in TOF, but you're not going to devise that ASD. So there's no point in measuring the rims of of the ASD in a patient who has got TOF or who has got a very large VSD or who has got some other, structural heart disease. So you should know the clinical relevance of what you are doing also.